Good morning, everyone, or good afternoon, I guess. I'm Mike Gisondi. I'm the Vice Chair of Education at Stanford. It's my pleasure to welcome you to today's session and introduce you to the LEAD program at Stanford. It's Leadership Education Advances Diversity, a wonderful program first started in the Department of Pediatrics at Stanford last year, expanded to a few other programs, including emergency medicine this year. So we have a panel that includes psychiatry, emergency medicine, and pediatrics all here at SAEM to present to you. I'll have them wave their hands as we introduce Emily Earl-Royal is here. She's a third-year resident in emergency medicine. Daniel Hernandez, one of our first-year residents. Nancy Rivera from pediatrics. Carmin Powell from pediatrics. Ripal Shah from psychiatry. And Alai Alvarez, one of our assistant program directors from emergency medicine. We have no conflicts. Oh, I do want to stay on that slide for a second and let you take a picture of that. All of our handouts are on this bit.ly, or you can use a QR code to get all of the materials that we'll talk about today. While you're doing that, I'll tell you a little bit about the LEAD program. So LEAD is a program that's meant to provide inclusion training around leadership. Again, started by the Department of Pediatrics. It's a year-long program. It takes house staff, both residents and fellows. They meet on Wednesday evenings for several hours once a month. They get an hour of training around diversity and inclusion topics meant to make them be institutional leaders eventually. It has a very clear and narrow lens. And then they meet in small groups with their lead mentors. I had the privilege of being one, as have many of the faculty here, in small groups to create workshops such as this. So not projects, but workshops, which have been submitted to a number of conferences, and we're very happy that SAEM took 3 of ours this year. American Academy of Pediatrics did the same. So our residents get to go around the country and present some of the work that they've created this year. So this particular workshop is about Diversity 3.0. And I will say that we're going to talk about some topics that for some of you may be very difficult. So I do want to acknowledge that some of the material we may talk about could be triggering, and I just want to give a little bit of a acknowledgement to that. We're going to be talking a little bit more about imposter syndrome, microaggressions, implicit bias, topics that hit hard and hit close to home, and probably have challenged most of you, if not all of you in the audience, as you've gone through your training to date. I'm going to tell you a little story about inclusion for myself. I have a lot of stories of times where I felt like I didn't belong, and when I felt lonely in my training. I'm going to give one example. I did 2 rotations in my 4th year of medical school to try to decide what specialty to go into. I did emergency medicine and I did anesthesia. And I was really struggling between the two. In my anesthesia rotation, I went to a suburban Chicago hospital that was in a fairly affluent neighborhood, and it was a private hospital. I was the only learner in the department at that time. And between cases, I went into the doctor's lounge, which was very fancy in my mind. You know, coming from an academic institution, this lounge had the fanciest coffee machine I'd ever seen. It was like going to Starbucks and that big machine, right? But imagine in a doctor's lounge, you could push a button and a cappuccino would come out, and like that was a big deal to me. I thought it was really cool. So I went and got my coffee, and I snuck in, I sat down, and all of the anesthesiologists that were in the room, who were my faculty at the time, were all easily above age 50. They were all male. They're all white. And they're all reading the newspaper that morning, and they're all looking at the stocks in particular. And one of them said to me, "Hey kid, what stocks do you have? I'll tell you how they did yesterday." And I said, "I don't have any stocks, sir." And I'll tell you that I was first-gen college. My dad was a fireman. You know, I didn't know how this. I still don't really know how the stock market works. I understand it's going up. I don't really know. So he said, "Well, what stocks do your family have? What stocks does your dad have? I'll tell you how those did." And I thought, well, I have no idea what stocks my dad has. And this went on and on. I couldn't wait to get out of that room. And I certainly did not feel like I was included. And that's what we're talking about today. We're talking about Diversity 3.0. We had Diversity 1.0 for a while, diversity for the sake of diversity, right? We need to look at a face sheet of everyone in your department. It just needs to look diverse, diversity for the sake of diversity. And then there's Diversity 2.0, which is let's have diversity in order to have better educational programs. The diversity of thought will lead to better learning. That's important. But Diversity 3.0 speaks to the issue of inclusion, right? It's inviting people to the party and actually giving them a seat at the table and talking to them. And that's what didn't happen for me that day, and I chose emergency medicine, went right back down to the ER, and I found my people, and I've been happy with my people ever since. But that's what we're going to talk about today. We're going to talk about diversity and inclusion. We're going to think about it through this lens of Diversity 3.0. So with that, I'm going to pass the mic to our next presenter.
Thanks, Dr. Gisondi. I just want to remind you about the trajectory of the face of America. We know that over the next several years, the United States is going to be a lot more diverse. And this is what's happening according to the NBC News. And unfortunately, what happens in academics is that amongst physicians, you'll see the color on the top there, white men, and then right below that, the green one is Caucasian women. And then you see at the very bottom, the line has not really budged a lot, despite the many efforts that we're doing for recruitment. And that's why we really need to look into the concept of diversity and inclusion from a lens of structural and institutional changes and really being part of our work. Medicine can be very isolating. This is a hallway, a very beautiful place at Stanford, and I just want to acknowledge how each of us can be isolated at times in medicine. I'd like to get a show of hands. Who here have felt lonely during your year in medicine? So I like that most of you have, and I can tell you that perhaps all of you have had this, right? Because it can present as vicarious trauma when you make a mistake. It can present as medical errors. It can present as that patient complaint. And when you get that, you remember those letters that are secure, and then you get that email from your boss, and then you start having palpitations? Because then all of a sudden you're questioning yourself. You're like, am I really good enough for this? I'd like to argue that in the same lens of talking about well-being, when it comes to underrepresented in medicine, we're going to be dealing more with implicit bias, microaggressions, and worse, the imposter syndrome. But sometimes people think that, well, I'm not a minority, and so maybe I don't have to deal with a lot of these diversity issues. In fact, somebody actually asked me, well-meaning person, very high up, asked, like, hey, I noticed you're tweeting a lot about diversity. You're not really diverse. And I was like, oh, okay. It was very interesting. And then I had to acknowledge that because I think it came from a good heart and just trying to find out like maybe how they can advocate for, as well. And I said, well, I'm not a woman, but I believe in the Me Too movement. I'm not black, but I believe in the Black Lives Matter. And each of us have felt or can witness some sort of marginalization that we can advocate, right? And I think that's what this is all about. We can all, each of us have the capacity to be an ally in our work. I would like to point out the concept of solitude because I think when we think of isolation or loneliness in medicine, there's a big difference between solitude, which is our choice. Sometimes we need that. We need a break from all the things that's happening to recharge, to rejuvenate, to try to think of creative ideas. And sometimes I just need that moment for myself. That's by choice. The problem with loneliness and isolation is that you really lose the connection. And that sense of connection is something that each of us need, whether you're a minority or anybody else. That's a human need that we have. And once you lose that, that's when you start having all these other problems. So let's go back to those topics, the vicarious trauma, the medical errors that I've shared with you, because that can all be isolating. And actually it boils down to the concept of shame. Right, so Brene Brown talks about this. If you really looked into the idea of implicit bias and the imposter syndrome, it boils down to how am I being affected? Maybe I'm not good enough to handle this because I'm ashamed, right? Because I'm not as confident as I want to be. And so I'd like to introduce Dr. Hernandez to talk about the imposter syndrome, and then the rest of the team will follow up.
Thank you, Dr. Alvarez. Hi, everyone. Thank you so much for being here. Again, my name is Daniel Hernandez. I'm one of the first-year residents in emergency medicine at Stanford. And I'm very excited today to talk to you about imposter syndrome. Okay, perfect. Okay. So what does imposter syndrome mean? Imposter syndrome was first described in 1978 as an internal experience of intellectual phoniness. In other words, it's not feeling like you're a fraud. It's not so much a feeling that you're going to, it's not the fear of failing. It's more of a fear of being discovered that you're an imposter by some significant person and that you're going to be taken away from your spot. is the feeling that your accomplishments are due to luck instead of merit, and that you do not deserve to be in the place where you are right now. It is a very common feeling, and a lot of us have experienced it throughout our careers. And I chose this topic because I've experienced imposter syndrome throughout my training. And I'd like to share with you a story that I hope exemplifies how I've experienced imposter syndrome. And it is just one of the stories, but sadly I do have many of them. And so I'd like to also give you a little bit of background just so that you understand a little bit of kind of where I'm coming from. So I moved to the United States when I was 14 from Mexico with my family. I started high school without knowing any English in the US, and that was very hard. I went to a high school that was very low resource, predominantly Latino, low-income families, where not a lot of kids make it to college. I was one of the few ones that made it to college from there, and the first one in my family to ever go to a four-year university. Now, you would think that I would have been living the dream by such a huge accomplishment, but instead, when I started college, I've never felt so out of place in my life. On top of this, I hadn't satisfied my college-level English requirement, so I had to take classes, like basic English classes, before I could take the real college-level writing classes. I went through this whole first quarter of undergrad, feeling like an imposter, feeling like I had gotten in by some sort of luck, feeling like maybe the admissions process made some sort of mistake. And so that I always had that on the back of my mind during my first quarter. At the end of that first quarter, not only did I pass my English requirement on my first attempt, but I did very well academically on the rest of my classes. And this might sound a little bit silly, but the first thing I did when I found out that I passed my English requirement was walk straight to the bookstore and buy my first sweater that had the university name on it. My imposter syndrome had been so strong that I had avoided to buy that sweater because of a fear of being, getting the sweater and then being kicked out of the university and going back home with this sweater. What was I going to do with it? I always thought. That was the first time that I felt like I belonged. But I had belonged the whole time. I had earned my spot with my hard work and the work of my family and my mentors. And I'd also like to mention that even when and 4 years later, I graduated on the top of my class at this university. So that just shows that, I did belong and I did earn my spot, but it was something I didn't realize until later. Similarly, the day that I got a call from a medical school that I got in, and even more recently, last year, during the match, and this is a picture of me, I couldn't escape that little voice on my shoulder that was telling me or asking me, am I good enough? Or did they make a mistake? And I'd like to emphasize that I didn't know that I felt like I was the only person that was experiencing this until pretty recently when I realized that, there's a lot of people that experience this and it's very common. Okay. All right. Okay. So just some data behind how imposter syndrome affects our trainees. This is a study from Thomas Jefferson Medical School where they interviewed about 150 medical students. And they found that being female gender is more strongly associated with feeling of imposter syndrome. So 49% of females versus only 23% of males. Imposter syndrome did attribute to burnout and feelings of cynicism in medical school. And they also found a higher association between fourth-year medical students and burnout. And here, it's important to mention that fourth-year medical students felt more like imposter syndrome because we do see this in times of transition, like I mentioned. Just like when I first got into college, or when you go into medical school, when you start residency, or when you first become an attending. And there's just some data that residents also experience it and attendings also experience it. So no one can really escape this. And I'd like to talk to you about some strategies that I found useful, and there's some data that shows that this is very useful. So what can we do at the level of an individual? What can we do to fight this feeling of imposter? So I think from this slide, the most important one is self-compassion. And self-compassion is important because it's very easy to focus on your weaknesses and oversee all the skills and everything that you bring to the table at whatever spot that we are on. We have to recognize that we are learners and that we will always be learners in medicine. And sometimes it is hard to put ourselves in the shoes of those who are above us, but we have to understand that they were at our spot at some point and that they got there maybe feeling the same way. Some interpersonal strategies that we can do. I think the most important thing here is the openness about the issue among peers. So just talking about it with those around you. And for instance, when I first started residency in my first week, after the first week of intern year, we met with our program director and we had this closed session where all the interns met and just to talk about how it had gone, the first week of residency. And you could just tell the scared faces of everyone in the room, and it was really quiet until someone shared that they felt like they didn't know what they were doing and that they just plain felt stupid during their first week of intern year. And you could just see in the room, everyone started talking about it, and there was this theme that everyone felt the same way. Everyone felt like a fraud. Everyone felt that they weren't contributing enough to the table. They felt underqualified. And since that day, it's been so much more easy to approach anyone in my class and just say, hey, you know what, I was feeling this way. And we can talk about it, and it really helps everyone. And lastly, what can we do at a level of an institution? So this is very important. I think giving it a name is the highlight here. Because once you give it a name, you know that you can do something about it. And also, the power of storytelling, I believe, is very important because just like I share my story, I think that really helps other people be inspired. And especially if you're an institution and you have a lot of trainees that you don't know their backgrounds of, or you don't really know how to include it, it's really important to let them know not just the accomplishments that you have as an institution, but also share with them the story of how you got there and share with them how you felt about it, because that really helps trainees feel included, and it normalizes imposter syndrome in a way that you can do something about it. And lastly, I would just want to emphasize again that this is a very common feeling and that it is an experience that is maybe different for everyone, but everyone in the room has experienced it. And I'd like to thank you again for being here. I hope you enjoyed the section on imposter syndrome, and I'm going to hand this off to Dr. Emily Earl-Royal, and she's going to talk to us about implicit bias.
Thanks, Daniel. Thanks for sharing your story with imposter syndrome. I know that's something that really affects all of us, certainly me in medicine and many other things, even speaking here at this conference, right, if I'm going to be totally honest with you. So the portion I'm going to speak about is about bias in trainee evaluations, specifically bias in written trainee evaluations. And this is a topic that I've been working on all year with an awesome group of folks from Stanford. And so we're just going to go over some of the highlights here today. So implicit bias, what does that even mean? So implicit bias are attitudes, stereotypes that we have that are unconscious, but they affect really our understanding, our actions, everything with how we interact in this world and all of our decisions. And why does that matter? Because the decisions that we make, the evaluations we make about people, particularly in an academic medicine setting, affect, starting in medical school, our clerkships. They affect our MSPE. That then affects where we go to residency. Do we go to fellowship? And further on, it affects our leadership positions, right? Who are our chairs? Who's leading emergency medicine moving forward in the country? So let's start back in medical school in clerkships. So they've done studies that underrepresented minorities have lower grades across all clerkships, even when you control for factors such as test scores, right? This doesn't make sense. Continues in the MSPE, so as you know, that big letter that is your summative sort of evaluation, white students are significantly more likely to be described with these standout ability words like exceptional, best, outstanding, bright. By contrast, students that are underrepresented minorities are more likely to be described with words such as competent. And this doesn't end in medical school. So this is a study from our own specialty in emergency medicine that was presented at this conference a few years ago, actually, on milestones for emergency medicine residents. And so as you know, milestones are supposed to be this very objective way to evaluate residents, very specific. But actually, we have found that in the beginning of residency, kind of looking at those blue bars, men and women are graded on a scale of 1 to 5, 5 being the best, with an equal frequency, sort of the highest frequency being 2. So sort of men and women are getting the same numerical evaluation. But something changes after that first year. And so by the time we're graduating residents, female residents, you can see with that solid sort of yellow-orange line, are evaluated most frequently at number 3, whereas male residents are number 4. And what this really equals is about a 4-month training deficit, so 4-month training gap. That's unexplained, right? We have the same training, but by the time we're graduating residents, male residents are being evaluated as if they're almost half a year more experienced than their female counterparts. So this is a study that was done to sort of look at that numerical difference and think about why are we evaluating male and female residents in emergency medicine differently. And what they found was, looking at the qualitative feedback for residents, that female residents are significantly more likely to get discordant feedback. So what do I mean by that? Feedback that is contradictory, that's difficult to follow because you don't know what you're supposed to do with it. One thing says to do something, something else says to do another. Whereas by contrast, male residents are more likely to get consistent feedback. Similarly, female residents are more likely to get feedback that is personality focused, particularly on 2 aspects of personality, so autonomy and assertiveness. And then by contrast, male residents are more likely to get feedback that is very specific or skill focused. So these are 2 very different ways that we're evaluating male and female residents. So here are some examples. So here's on the left in the sort of red box is a quotation from this study from a real evaluation of a female resident. It said that she responds negatively to my input, that she has a negative attitude towards supervision. And then if you look at the male resident, what does he get? He gets that he's sometimes argumentative, but actually he's trying to assert his confidence, right? So you can see they are the same behavior of having a little bit of resistance or independence, right? In a resident, for the female resident, that's viewed very negatively, and she's penalized for that. The male resident is applauded at trying to assert his confidence for the same behavior. I will say that I have personally gotten feedback like this. I remember in medical school, the first line said, feedback, not confident enough. Next line, too confident. What am I supposed to do with that? How do I get better? It wasn't helpful. And then, we're talking about this. We're here at an academic emergency medicine conference. We want to move forward, and this really affects not only in residency, right, but then who goes on to lead our field. So this is a graph showing female faculty in medical schools, and you can see the lowest level instructor is actually majority female. That's that top kind of purple line. And then every level, as you advance in promotion, the percentage of women drops. So kind of going up, assistant professor, you drop. Associate professor, you drop. And then full professor is the lowest, just above 20%. And this is really unchanged over the past 10 years. Similarly, looking at ethnicity differences, so you can see this is male medical school faculty, and that most of the people who are our male school faculty are white. And then there's about 20% Asian, and all of the other races and ethnicities over this 10-year period are near 0. And that line is a flat line. It's not changing, right? So what can we do about this? That's a lot of very depressing data. But that doesn't mean there's no hope. There are things we can do. So we've sort of broken it down into 3 different levels of change, right? Individual level, so that's you yourself. And building on that, you can do interpersonal, that's what we think of as at a program level. And finally, institutional levels, so thinking about sort of the GME or larger boards that cross different programs. So recognizing individual bias, this is a big step. Some of you have probably done this test. It's on Harvard's website where you can do an implicit association test to look at your own biases. And the first time I did this test, there's one for women, there's one for multiple different races. I was very angry and I thought that this website was flawed because it told me that I had a very strong gender bias. And I was very upset because this is something that I have really been aware of my whole life. And in kindergarten, I did my own study, unprompted, where our teacher, male and female students, would raise their hand. And on my own, as a 5-year-old, I recorded the number of times that the teacher called on a male student versus a female student. And then at the end of my study, I gave my teacher that feedback, which she did not appreciate. And then my mom got called. But, you know, this is truly something that I've thought about my entire life. And I have very strong gender biases, right? It's not something that just because if you're aware of it or you don't want to have it, you can't get rid of it. We're all raised and socialized in a society that shows you different things. And so it's important to be aware of what your biases are. So kind of moving on to more of a interpersonal level, training evaluators. So many of you guys, right, evaluate residents all the time. We evaluate med students, we evaluate each other, right, professors are evaluated. So there are different strategies that we've come up with. Stereotype replacement is one. So if you notice that you're using words that are particularly stereotyped for a specific group, for example, if you write the word competent for a student that's a minority, switch it out, right? Change it to bright, talented, outstanding. Counter stereotypic imaging. So when you're writing a letter or evaluating someone, try in your mind to think of an image of somebody who counters that stereotype. So when we were coming up with this presentation, one of my colleagues is a tall, black resident, and he said, think about someone like me, tall, black, athletic. I played tennis in high school, not basketball, right? So think about somebody in your life that you can use to counter that stereotype. Individuation, meaning knowing that person well enough to give them specific examples. So basically show, don't tell, right? You don't have to say that someone is compassionate or smart, but you can give a specific example of how they came up with a specific antibiotic choice that was really key to, I don't know, either cost effectiveness or resistance effectiveness or something that someone did for a family, giving very specific examples. And then finally, increasing opportunities for contact. You have to know the person to be able to give valuable feedback. So did you really work with that person enough? Have you seen that person at an EMEG event or a conference? Making sure that you increase time with that person so that you're able to give valuable feedback. This is from a New York Times article, also on feedback. Surprisingly, or maybe not surprisingly, most of the data that we have on giving unbiased feedback comes from outside of medicine, so from business. But so some suggestions that they have include focusing on specific skills rather than personality traits, right? Giving feedback on personality is really not helpful. So giving feedback on very specific things that someone can work on. Making sure that your criticism is actually applicable to the job at hand, right? If it's not applicable, don't mention it. And then balancing positive and negative feedback. And then on an institutional level, we don't have a lot of data for this, but being transparent, accountable, doing evaluations over time to look at trends of your own department or institution. A great place to start for this would be the GME because they have data on all of us, not just in emergency medicine, but all of the specialties. So they're really an opportunity for us to do a lot of learning here about trends across specialties and over time. But it's a big cultural change that's going to take time. So in summary, implicit bias negatively affects medical evaluation, particularly among women and underrepresented minorities. But there are a lot of strategies, particularly standardized evaluations, to help us reduce the implicit bias that we have in our evaluations. Thanks. And now I'm going to transition over to Carmin and Ripple from Pediatrics and Psychiatry.
Hi, I'm Ripple Shah. Dr. Powell and I are going to talk to you guys a little bit about biases and microaggressions, including a tool that we've come up with at Stanford to help address microaggressions in the clinical setting. I always say that I study bias academically and clinically because as a psychiatrist I see the psychological consequences of bias and microaggressions on a daily basis. I've also witnessed it personally. I come from an Indian African household where I'm not seen as black, but I have a fraternal twin sister who is black appearing and is seen as black by society. So we joke that we were enrolled in a controlled experiment at birth of how society treats you. Even when you have the same teachers, the same parents, the same diet, everything is the same, but just how society views you and how that can change your experience and the lens with which you walk through the world. So there's we have quite a few studies from the late 90s, smaller studies since then on medical residents and their reporting of experiencing discrimination during training. So 60% of female residents reported having gender-based discrimination by families or patients, 35% of African Americans, Hispanic as self-reported on the study, and Native American medical residents reported discrimination, and 60% of Middle Eastern medical residents. Like I said, we actually think the data is showing even higher numbers since then, in part because people are more aware of biases and discrimination more now and are more willing to come forward with it in survey data, but the data is more intradepartmental and smaller. So in terms of bias and microaggressions, I like to think of bias as the process that's going on and microaggressions as the action that's happening with that process. So a bias can happen either implicitly or explicitly. Either it's happening and you know it's happening, so it's an explicit bias, a positive or negative mental attitude towards a person, a thing, a group that a person is aware of and is conscious, or an implicit bias, so something that's similarly positive or negative mental attitude but happening on a subconscious level. And then a microaggression is the way in which those biases play out, whether that's in clinical settings, peer-to-peer, numerous places where it has an unpleasant psychological impact. And so an important piece of this is microaggressions can actually be positively based or negatively based. They can be intentional or unintentional. So an explicit bias, for example, would be a program director saying, I don't want to interview black applicants because I don't think they make good residents. An implicit bias would be all of the black applicants are at the bottom of the rank list, even though the step 1 scores and clerkship grades are fairly similar to other people, in part because of interview evaluations like we discussed. And then a microaggression would be that applicant comes and has started in the program and unintentionally positive mental attitude of, wow, you've really come a long way. Good for you for making it here to be a doctor at Stanford. And imagine if someone's already feeling isolated and like they don't belong, and then they're hearing this thing that doesn't necessarily have bad intentions but can be further isolating.
And so when we talk about implicit bias and explicit bias and also microaggressions, we realize this is a very large conversation that cannot be encapsulated in a talk for just 1 hour, but we do encourage you to continue this conversation, but realizing that it's really hard to have, or even knowing the best way to go about it. So why is this the case? Oftentimes there's a lot of embarrassment around just kind of the incident or the phrase that was said to someone. Also, there's a lot of uncertainty with how to start the conversation. What's the first thing to say? How do you kind of, assuage the situation and make the person who received the microaggression feel comfortable and safe in having this discussion with you as a bystander? Also knowing that there needs to be some therapeutic alliance or collegiality. So realizing if you're working with a new trainee or a medical student that you haven't worked with before, it can be very hard to all of a sudden come into this conversation wanting to say the right thing or trying to think about what's the right thing to do. Some ways we think about this, unfortunately, in the medical profession is whether we address it or we don't address it. Oftentimes, this happens in moments of very high stress. I can think of definitely patient encounters, definitely on the pediatric side, where families have requested not to have a certain physician of a certain background or ethnicity as a provider for their child, but realizing your goal is to take care of that patient. So in those moments, it may be more adaptive, and you don't say anything, and you don't really want to change the relationship with the offender. But then sometimes there are generative strategies where there is a potential, if you do say something, that you will change the dynamic in the relationship with that offender and maybe disrupt that therapeutic alliance. Just a quote from Brene Brown, you can choose courage or you can choose comfort, but you cannot have both. And I think that's something that we often struggle with as physician providers. So something that we did last year when we first started our LEAD program, a group of residents came together and said we really want to figure out a way to unpack biases when they do happen in the clinical setting, and really thought of it as almost like a code. So when a code happens, you have, everyone in certain places, you have a whole assignment of roles and what people must do, but then also you debrief the code afterwards to find out what was the right steps that were taken, kind of understanding the situation. So we kind of use that same framework with developing this tool that was a way to discuss biases and really can also be used for microaggressions, and also hopefully helping to change the culture by having a more structured framework. The tool itself, we use 5 S's because, acronyms are everything. But really the idea is using these different parts to really kind of facilitate the discussion. So the first S, space, really kind of looking at, are you even in a safe space in the right environment to start this discussion? It might not be the best to do this right in the middle of a trauma to start this discussion. You might want to have this outside of that clinical environment. Also making sure you're setting some expectations for the conversation, and also if you're the one who's going to be the one starting at being open and really having active listening. Also self-reflection, really asking for the trainee or the person who's experienced the bias or microaggression to have more of a reflection of what happened, encouraging mindfulness, and also making sure that you're there to provide emotional support. For the situation, really try to objectively evaluate what happened, exploring the different perspectives both from the offender and the offendee, and also making sure you've developed a shared understanding of the situation that happened. Solutions, really looking at what are the next steps. What we really learned from trainees, we did a study last year looking at discriminatory patients and family interactions, and what we learned the most from trainees is they want to be a part of making up the solution or what should be done. They really don't want us as faculty to come in and tell them what to do. So really allowing that opportunity for them to think through this process, and also encouraging them to have this difficult conversation, and then ultimately support. I think we'll talk about this a lot, but really providing validation, also supporting with empathy, and also offering to check back in. So while you've had that conversation in that one moment, making sure you're checking back in with a trainee to see how are they doing, because realizing that we may see these slights happen once, but the trainee may be experiencing this all the time, every day on the shift, throughout their life. So it's really important that you go back in and you check in with them on how they're doing. And then also providing resources specifically for institutions. What do you do in those situations? Are there policies against discrimination and harassment, and actually showing trainees that your institution is buying into this as well. Also, we want to look at what can you do next. So of course you can look at it in 3 different frameworks of the individual, learning how and using tools like this to really interrupt the microaggression or bias that happens. Interpersonal, so are there opportunities that you may have to train your faculty to have this skill set? Because we know that communication, while we may think we're really good at it, there is definitely something to be learned and explored in this area. So are there opportunities for having communication workshops? How do you do crucial or very conflict-oriented conversations? And also opportunities for faculty development in this area. And also looking institutionally. So we also did a learning climate survey, because it's one thing to say this is happening anecdotally, but really to capture it. So actually surveying the residents and finding out what is going on in your clinical environment and being able to capture that so you have the best intervention for them. So take-home points, bias and microaggressions occurs frequently in medicine and everyday life, and these tools are just guides to really help having a more controlled and more useful debrief when this happens in the clinical setting, and really making it more safe and supportive for the trainee, and really being a place where you can have an open dialogue. And the first step is really kind of bringing awareness to this, so having these conversations, using this terminology, because we know a lot of this is relatively new and coming from more of social psychology from business, but also putting this into medicine and the context of what we see and what we do on a regular basis to change the culture. All right, next, Alai.
Thank you. So we talked a lot about many things that prevents somebody from feeling included when we get them in our institution. And so let's take this home. Where do we go from here? So we talked earlier about the concept of isolation and loneliness in medicine and how it actually is universal. Everybody here has felt lonely at times, and we've shown you even more reasons why this can happen. At Stanford, we looked into the idea of professional fulfillment, and you really need to have the culture of wellness. You need to have efficiency of practice, but there's also the idea of developing some personal resilience. One way to really focus on this concept of the imposter syndrome that Daniel Hernandez was talking about is developing this sense of self-compassion, right? Because at its core, a lot of this, whenever we get those bad letters or the medical errors or the complaints, it's when we start questioning ourselves, do I really belong here? Was I a good doctor enough? Or am I a failure? And having the self-compassion is key to realizing that, hey, I can actually change things if I can learn to forgive myself. Because once you disrupt that rumination of, I'm not good enough, then you can focus on the accountability and how you can actually improve as an individual. Kristin Neff talks about the concept of self-compassion in 3 things. First thing, you need to be self-kind. You have to be kind to yourself in order to develop self-compassion, but it doesn't end there. You need to have this sense of common humanity. Just as what we did earlier at the very beginning of this talk, we acknowledge the fact that we each have felt this sense of loneliness. We've had bad outcomes, we've had medical errors, and that it's not unique to us. And knowing that and understanding that is very important in developing self-compassion. And lastly, this key concept of mindfulness, and this is not the yoga or meditating really, but it's the idea that we're human beings. And so when we notice that, ooh, I'm having that thoughts again, that I made a mistake, I'm not good enough, you just key in on that and being present and saying like, ooh, I'm doing it again. And the more you do that, the more you realize that this is happening, you're more likely to intervene as opposed to you didn't even notice that you're doing it over and over again. In medicine, there's a lot of talk now about shame in medicine and how we need to get that level of connection. In emergency medicine, because we were the highest burned out physicians out there for the longest time, we've created areas where we can develop connection. Things like the Airway series, where we talk about our mistakes or the cool things that we've done. Renee Myers talks about, and Dr. Gisondi mentioned this earlier, diversity is being invited to the party and inclusion is being asked to dance. In our group, what we learned is that it's easier said than done, because when we've invited you to actually go for the dance, you may not know how to dance yet. And that's the purpose of really truly understanding what inclusion is. And it's okay to have mentors and guides to help you learn those skills. Normalize that the imposter syndrome is common. Normalize that it's not going to be as easy, but they believe in you, that you're going to be able to accomplish it, right? So somewhere in between, you have to cultivate this and to teach the concept of inclusion and really being there for that person. And then hopefully at some point, you develop this sense of belonging that you dance as if nobody else is even, you don't even care what people are thinking about you. And that's when you finally belonged. And you know that boils down to the concept of psychological safety. You really need to feel that you're safe in that space to dance the way you want to dance without really knowing a whole lot yet. Because you can be alone in a very crowded room, and what really helps is that sense of psychological safety. And I'm going to highlight that in underrepresented in medicine, it's a lot worse, because you deal with the daily bias and microaggression that we just talked about. You have this minority tax that just because you're the minority, you feel like you have to do more than the rest of your colleagues. And then you're navigating, you're negotiating this, your personality. Like, do I do the diversity work? Do I do this X, Y, Z? Like, what if I want to be an astronaut? So you're always trying to negotiate your presence. And this is where mentorship matters. This is why each and every one of you here has the capacity to actually make a change for somebody to feel included in each of your programs. Because the data shows that 50% of underrepresented faculty members have no formal academic mentorship. So if we're talking about belonging and making sure that we have a robust well-being culture, we need to make sure that people are mentored to actually feel that they belong. I'm going to quote Teresa Smith here. She said this at CORD a couple of months ago. Appreciating diversity and appreciating diversity and practicing diversity are not the same. Just as we do the same thing with wellness. We can talk a lot about wellness, but if you're actually not practicing it, It's not the same. And so it's really on us to develop this sense of compassion, not just to ourselves, but for each other, because we need to move on from just recruitment in the diversity 1.0, increasing the numbers, to diversity 2.0, when we have a sense of inclusion, but it's really not there. People don't know how to dance yet. Into creating a systematic changes, institutional work that allows for people, for everybody to feel included and for people to feel that they belong. That's how we're going to be able to accomplish not just improving diversity and inclusion in our work, but also really truly believing that we can get better with our wellness and preventing burnout in medicine. I'm going to end with a quote from Vivek Murthy, who's one of the Surgeon General. He talked about this at the first American Conference on Physician Health. We are people responding to a calling, and all of us can be a part of that effort. We are brothers and sisters in medicine. So I know that we've done so many things here at SAEM. There's so many cool stuff that we're doing. And I know that you're inspired right now, but I'm going to ask you to do one thing. I'm going to ask you to open your email and pick one thing that you will decide as your goal to develop. Because you're going to forget about many things today, because you're going to do so many other things. There's a big party tonight. But email yourself, right? This is what I learned today about implicit bias. This is what I learned today about microaggressions or the imposter syndrome. So when you go back home, you'll remind yourself. And then email again yourself what your institution should focus on. And perhaps next year we'll have another conversation, and how else can we drive this conversation forward. I'm truly grateful for you being here today. And many of this work would not have happened without Dr. Powell's inspiration at the very beginning for creating the LEAD program. You'll be able to find out about the LEAD program later on with the links. You can Google us. And these are the many other groups, and there's many other that I couldn't fit here because I tried to make it as pretty as possible. The notes for this talk is going to be in that bit.ly. It's probably not updated right now because I didn't want to give you all the answers to our slides before you come here, but we'll update that by the end of the talk. And since we're a little bit early, I can give you that time, or I can see if this video will work. And this is the LEAD program. And I guess there's no audio. So, but you can look this up online. We're happy to take any questions at this point. Thank you again.